Hello and welcome to ScheinTV. I'm Peter Norton. Thanks for joining us for our first episode in the series. Today we'll be talking about maximising clinical success with GICs, what to use and when. Glass ionomer materials have been used in dentistry since the 1970s. After 4 decades of research and development, there are now over 30 GIC products available in Australia, so there's plenty of room for confusion about clinical indications for their use, as well as correct technique. Fortunately for us today, we're joined by Professor Ian Myers, who will help us to chart a course through this sea of confusion. Prof Myers, welcome to ScheinTV and thanks for your time.
Thanks Peter, it's great. I'm looking forward to having lots of discussions about glass ionomer tonight.
Same here. Our event today is scheduled to run for approximately 1 hour and we have a lot of great content to cover. Throughout the event, we'd like to encourage you to engage with us here as we test your knowledge and answer some of your questions. In order to do that, I'd like to ask you to take out your smartphone right now, open your browser and go to the website shown on your screen. It's schein.tv. Once you've done that, click connect and you're good to go. We'll be doing some polls very shortly, and as each question is asked, please wait for the corresponding question to appear on your smartphone, then you can respond. Your answers are entirely anonymous and we'd like for as many of you to participate as possible so we can find out what we know and don't know about GICs and their use. Once the polls are finished, we'll get to the so-called meat in the GIC sandwich with a brief presentation followed by a clinical demo. During that part of the event, you'll be able to send us your questions via your smartphone and we'll get to as many of those as we have time for. At the end of the show, you can register to receive your CPD certificate by clicking the button below. So, with all of that ahead of us and only 1 hour to do it, it's a good thing Prof Myers needs almost no introduction. Prof Myers holds honorary positions with the University of Queensland and James Cook University. A former Chief Dental Officer for Queensland and past President of ADAQ, Prof Myers is currently a Chairman of the ADA's Dental Instruments, Materials and Equipment Committee, and also consults to a range of dental companies on their products. With all of that, Prof Myers still finds time to maintain a private dental practice. Prof Myers, if I can start with a question, how much confusion do you think there is around the use of GICs and where do you think that confusion comes from?
It's a good question, Peter, and I think that GICs have been around for a while and people have got used to their use, and initially they were thought as being fairly simple materials or temporary materials, and then over the years there's been lots of variations, lots of modifications to the products, and so I think now there's lots of different options for where we use our glass ionomers and lots of different clinical situations where they can be used. So, I totally agree there's lots of confusion. And probably on that, I'd like to sort of start off with our first poll question, just as a general question to the audience out there, and just think about where do you as clinicians use your glass ionomers most? So this first question is just a broad one about where do you normally use your glass ionomers and what sort of materials do you use? So do you use conventional glass ionomers simply as a base or liner? Do you use the resin reinforced glass ionomers as a liner or base? Do you use your conventional glass ionomers as a full restoration right to the surface of the tooth? Or do you only use resin reinforced glass ionomers as a surface restoration? Of course, you might not do any of those and you can select option E there, I don't use any of these materials. And of course, when I talk about resin reinforced glass ionomers, I'm talking about the resin modified glass ionomers. People talk about those as being RMGICs or RRGICs. I'm not making a separation in those classifications, I'm putting those both together at the same time. What I'm hoping to see here is whether practitioners look at using a particular material in a particular instance, or whether they feel there's a lot of broad ranges. I know many practitioners will probably look at this and say, well, there's all sorts of applications for those different materials, but I'm just asking for the one that they use the most. Now we're going to be getting some results coming in fairly soon, and I think Brett's coordinating some information for me there, and we'll sort of see what we've got. And as you can see from that, a third of the people out there or more are using their conventional glass ionomers as a liner or base. And then also quite a few as a full restoration. Not so many using the resin reinforced glass ionomers as a surface restorations. And about 10% of the people out there not using glass ionomers at all. And I think that's a pretty good representative sample of what's going on there. So if we can move on to our next question, and this is a bit more specific. And what I want to do here is just look at some glass ionomers and see if people really understand the difference between those resin reinforced and the conventional glass ionomers. So in that list there of 6 materials, and I am only focusing here on the GC products, but I want to talk about which ones of those lists you see as being resin reinforced. You can select multiple choices here, of course, multiple answers. Several of those are resin reinforced and some aren't. So And I'm really looking at the addition of the resin to either improve the strength properties of the material, the aesthetics of the material, whether we're looking at changing the handling properties of the material. And you know, it might be difficult for some practitioners that don't know about some of these products. Some of these are fairly new onto the market, and it might be that we're finding some of them aren't used already by practitioners and they're not really sure yet. But we're going to cover that as we go through the evening and talk about these products in a bit more detail. So we're starting to get some answers coming in, and thanks everybody for your responses on this, because I think it's going to set a really good scene for tonight's discussion. And as I expected, everybody knows that the Fuji 2LC, very commonly used, is a resin reinforced GIC. And the other resin reinforced GIC there is actually Fuji 8, the third one in the list there. Only 12% of people are noting that. All the others are conventional glass ionomers. So the Fuji 7 EP, the Fuji 9 Extra, Fuji Fort Fill, and the Fuji Bulk, they're all conventional glass ionomers. So the only two in the list there are the Fuji 2LC and the Fuji 8 as being resin reinforced glass ionomers. We'll move on to our next question, and this is an interesting one too, because this is looking at why, as a practitioner, you choose your glass ionomer, and what is the most important property when you choose that glass ionomer. Now again, you probably think there's lots of things there, but I'm just looking for the one answer here. I want you as the practitioner to think, what is the most important thing to you? Is it adhesion to the tooth structure? Is it the fluoride release? Is it the aesthetic outcome? Is it the strength? Or is it the handling? Certainly as practitioners, we all want things to be wonderful handling. We like them to be used so that we can use them easily and it's not difficult to use. And you know, I know that if I was answering this question, there'd be a couple of answers I'd want. So it's sometimes hard to choose the most important one there, but I'd like our audience to try and narrow it down to get the most important one there. So as our results start to come in from this one now, we're going to see a few interesting results, I think, from this one, because I think there'll be a fairly broad spread across the whole spectrum.
I agree. As the results do come through, are you going to tell us what your favourite?
Yeah, I'm going to try and leave that to the end. I'm going to cover some of the topics as we go along, and because I don't want to give too much away, I'd like people to think in their own minds what they use it for, and hopefully we'll go through and either confirm their thoughts or maybe have another rethink on how they're using the materials and why they use them. So yes, I think the adhesion to tooth structure and fluoride release are always going to be the major issues there, and the really big important things. And I think that that's really good to see. I think we all accept that the glass ionomers may not give us the wonderful aesthetic outcomes. All right, let's move on to a more clinical question here. And what we've got here is a bite wing radiograph that's showing a couple of clinical concerns. And what I'd like everybody to do is to have a look at that and think what they think is the most significant concern in that radiograph. Is it subgingival calculus and bone loss? Is it the presence of restorative pins? Is it the restoration washout? Is it the poor interproximal contour and contacts? Or is it the fact that there's some dental caries there? I think that's got a fair few things there to think about. I'd have to say there's some probably not ideal situation for this particular patient, but if you could think about this, you know, as a patient that came into your practice, you've done an examination and you've taken some radiographs and you've seen this, what's the one thing that you're going to probably look at first of all, the one thing that concerns you most when you see this sort of image on a radiograph? Because, you know, there's probably a few suboptimal things there that aren't ideal that we'd like to have slightly better.
Definitely.
So, some results coming in there, and yes, the big things coming in there is that the subgingival calculus and bone loss, and the restoration washout, and the dental caries. Look at that. I mean, I totally agree. In my mind here, it is all about the subgingival calculus and bone loss, because to me it's about the patient hygiene, it's about the oral environment that we do restorations in. As you'll see as I go through the day, I'm going to try and dispel some of the myths around restoration washout and whether or not we can look at that. And certainly I'll go back and look at that later, and we'll talk about the caries aspect as well.
Excellent.
All right, final question I want to put before we get into some of the presentation is, if you were doing an open sandwich restoration, and I know not everybody does these, but if you were doing the open sandwich restoration, what would be your choice of glass ionomer from the list that's there? And again, I have only selected the GC products here. I know there's lots of other products around, but just in terms of what we've already discussed in terms of resin modified and conventional glass ionomers, which would you as a practitioner choose out there? Now, you may do none of them and of course choose answer G if none of the above suit, but I'm talking about the open sandwich where you've got the deep interproximal margin down to dentine. There's no enamel left at that dentine margin, so you're looking at some sort of open sandwich with some of the glass ionomer exposed.
And something that won't show up when the patient smiles.
Yeah, we're looking more at the further posterior restoration, something that's not in the aesthetic zone. This is going to be probably back on a first or second molar where you've got some maybe deep subgingival caries. So we've got some results back on that now, and I think it's fairly obvious there's a couple of big winners there, the Fuji 2LC and the Fuji 9 Extra. And I think that's probably reflective of the products that have been around for a little while and what people are using out in practice a lot. And certainly I think that we'll review that a little bit later once we've had a discussion on the types of material, what's in them, and which ones I choose and which ones I recommend for the individual patients.
Well, now that we've done with the polls, keep your smartphone handy because you'll be able to use your smartphone to send us questions, and Prof Myers can then answer them for us. If I start with a question about restorative pins, you mentioned them in the clinical X-ray film earlier. What are your thoughts around pins? Do you use them? Do you have any concerns around them as well?
Yeah, I have to say, Peter, it is a good question, and I use very few pins these days. I think with our new adhesive technologies that there's less and less need for pins. We can get really good adhesion through our GlassIonomers and some of our adhesive bonding systems. I have more concerns about pins and the risks that are associated with it, and that can be stressing the tooth structure, causing fractures within the dentine, and also the possibility of leakage around those pins. Unfortunately, all composites eventually have a tendency to leak, and if you've got a pinhole, the caries will go around that, and you get a fair bit of destruction around that. But I do say that if I am using pins, that I always like to use some sort of cement to cement them in. I tend to use, if I am using a pin, I would tend to use the self-threading type pins, but I'd always cement them at the same time.
So dipped in cement and
then use a resin modified GlassIonomer because I know that's going to bond well to the pin and also create a good seal around that, and we'll talk about some issues around that later. But in general, I would suggest when you're using adhesive tooth coloured materials, and particularly GlassIonomers, it's not my major way of getting retention.
Great.
Well, I think that sort of gives us a good chance to now move into the presentation I want to give. And I want to give a couple of bits of outline. And I know I don't want to make this too heavy a scientific program tonight, but I do think there are some things we need to look at in terms of the science behind the GlassIonomers and the clinical application. So we'll move in a bit and talk a little bit some of the issues. And there's no doubt in current general practice that direct placement tooth coloured restorations are a huge part of our practice. And while composite resins have been around and used for a long, long time, they are quite technique sensitive and they can be quite difficult and time consuming to place. I think as the GlassIonomers are improving over time, we're getting better products, and in fact, in some situations they can be the material of choice. A couple of years ago, Trevor Burke came up with this nice little paper, and he concluded at the end that under certain circumstances, GlassIonomer materials may provide reasonable service. Whereas in the past we always thought about them as temporary or interim materials, a lot more now anecdotal evidence would suggest that we can use them in situations where they may be a little bit longer term. So where are we at this? I mean, traditionally GlassIonomers were defined as being either eluting cement, a restorative cement, or a lining cement, and we talked about type 1, 2 and 3, and then we included those that were the resin reinforced or resin modified. There are so many products on the market. I've got a huge number listed there from the various manufacturers. And in fact, I just go to one of the manufacturers and I'm going to look at the GIC website here, and they've got 14 different types of GlassIonomer simply listed on their website. So we've got a huge range of products out there, and I'm going to touch on some of these today and their advantages and disadvantages. And I would always recommend to practitioners when they're using a product for the first time, go to the manufacturer's website, have a look at it, because there's usually a wealth of information out there and there's some really good information that they can get. So a lot of the stuff we won't have time to cover tonight. I thought I'd show you, this is a selection that I have in my practice. Not many people are going to have this many GlassIonomers out there, but
pretty impressive.
But I think you've got to realise that they do colour code them and they do have applications. So when someone says to me, I use a Fuji, I think, well, that's not enough. I need to know more than that. Which one of the Fujis are you using? Because there are so many. I think it's also important that you get your staff trained up to understand which is which as well. Because, as we know, once we activate one of these capsules, that little coloured button disappears inside the capsule, and you really need to know that your dental assistant is passing you the appropriate product. So, GlassIonomers, where do they sit in adhesive dentistry? I think we all accept that composite resins and GlassIonomers are completely different. We know that our composite resins are a lot more aesthetic, and our GlassIonomers are more the adhesive acid-base reaction. Composite resins, very aesthetic. We can do some modifications by either adding some glass particles to make them a little bit fluoride releasing, and that was the so-called polyacid modified composites, the complement materials. The other side was to go to the adding some resin to the GlassIonomers, which you've already mentioned, which is the resin modified or resin reinforced GlassIonomers. So which material as a practitioner do we choose? And I think that's really got to be influenced by the patients that we see and your individual practitioner needs. I don't think you can say, I'm going to use this one particular product for everybody. I think we need to be aware of all the variations. So, what are the key messages I'd want to get it back? I think we need to realise that GlassIonomers are still a water-based chemical set material. They're not light set. And even though sometimes we add resins to them, which might be light setting, then still a chemical set material. You're still going to have two parts that you mix together. Because they're water-based, we have to make sure that we don't get them wet while they're setting or dehydrate them, because the water balance is really important. They are iron-rich materials. We've got to make sure that we get the maximum out of those materials. And because there now are so many variations on it and so many different ways of preparing the two structure before you adhere these materials, you need to make sure you're using the appropriate conditioner with the appropriate glass ionomer. Mixing and activating the capsules, it seems straightforward, but I see so many people make mistakes because they haven't activated and mixed the capsules correctly, and I'll run through that a little bit later. And probably the most important thing to me is that as an adhesive material, they're most effective when they're still in their active state. In other words, where you've still got some of that liquid reaction available to go with two structure. And you can tell that with the glass ionomers because they're quite glossy when they're first mixed. Once they lose that glossy surface and they go a bit putty-like and dry looking on the surface, they're not going to interact with two surfaces, so you're going to lose a lot of that adhesive ability. So I always make sure that when I'm placing my glass ionomers, they're still fluid, they're still glossy in appearance to maximise that adhesion to the two structure. So, what are you going to use and what are you not going to use? Difficult one. Obviously there are certain practitioner expectations, and I think we've got to mix that with patient expectations. We want it easy to use, we want it adhesive, we want it therapeutic wherever it can be. That lovely term biomimetic, can we make it mimic the biological environment? Is it really a true dentine replacement? How aesthetic is it? Is it resilient? Is it economic to purchase? Because at the end of the day, we've still got to pay all our bills. And of course, the patient's going to want something that's easily placed, looks aesthetic, and lasts for a period in time in their mouth, and they don't want it to be exceptionally expensive as well. So, are we there yet? Do we have a universal material in the glass ionomers? I have to say no, unfortunately. I'd love to have the one product that I could use everywhere.
Wouldn't we all?
But unfortunately, I think that's why we've got so many glass ionomers out there now. I think it's because we've got so many different choices and no one is particularly brilliant, because not all patients are the same, not all mouths are the same, and certainly teeth aren't the same. And of course, not all clinicians like the same materials. So we need to sort of unravel this and say, well, okay, what have we got as good options here in terms of that? And I would say, don't just say, choose my material based on like properties or the colour of the packaging or anything like that. To me, it's about, let's have a look at the patient and what we expect as the outcome. We've got to think about age of the patient, the oral hygiene of the patient. The new term level of dependency is coming out because, I get a range of very elderly patients in my practice, and some of them are very capable of looking after their mouths and some of them not. They need a lot of care. And I think glass ionomers are often placed in those situations where they think, oh, I can just place this in here because that patient's not going to be around for much longer, or because it's not really essential, I get ultimate aesthetics. But I think you need to think about what's going to be best for the patient as well as what's going to be easiest to use. Obviously, caries risk, erosion and tooth wear risk, what's happened in the patient previously. Saliva to me is a really critical thing with this, because you need to look at the oral environment, you need to decide how well is our glass ionomer going to last. Obviously, don't forget to look at the periodontal status. And one thing that people often forget is that when you see a patient at one visit, the risk can change later on. And so you can place something in a particular patient at one visit and then down the track say, oh, gee, there's been a change in the risk here, I probably should change the material I'm using.
You've mentioned salivary status. How would that affect your material choice?
I think one of the issues that people worry most about is that, if you've got a low saliva flow, you're going to end up with a slight increase in acidity in the mouth. And for many years, people have been worried about glass ionomers dissolving in acid environments. And to a certain degree, that's true. But I also think it's a very protective material in those mouths because it's able to neutralise a lot of the acidic production in the mouth as well. So there can be big benefits in that. And quite often I'm looking at the ion exchange in some of those materials to try and make sure that I'm enhancing the oral environment as opposed to just worrying about what's going to happen to the restorative material. So, I think it is tricky because, we think of enamel and dentine as being fairly uniform structures, but they're not really. Enamel can be very variable. There can be differences between healthy sound enamel and demineralised, hypermineralised, or even hyperplastic enamel. Much harder to bond to that. Deciduous, permanent, prismatic, aprismatic enamel. And that issue of whether you cut or you don't cut enamel. These days of MI dentistry, we're doing a lot more just cleaning the surface and bonding onto it. And does that affect our adhesion? And dentine, even more complex. It varies between younger patients and older patients. Whether it's vital tooth, non-vital, sclerotic, very mineralised tooth structure. And obviously when you get the very heavily mineralised tooth structure, you think glass ionomer is going to work really well because you've got all that mineral. And in general terms that is the case, but not always. And I think how close we are to the pulp, is there going to be some pulpal irritation? What is causing pulpal irritation? We need to think about issues around that. So I think again, I'm going to keep going back to this and saying, don't just have one material and think it's going to do everything. We need to consider the patient, we need to consider what we expect as our outcome before we choose it. You know, when you've got demineralised enamel, and we know that we get these cases where, whether it's a younger patient with some demineralisation or an older patient getting some root caries and root surface demineralisation, these are hard cases to treat because you've got a tooth substrate which isn't particularly good to bond to. And quite often we need to improve that and enhance it before we start using any of our adhesive materials. So, two aspects I want to talk about when you're looking at these glass ionomers, and that's the issue of what we call the seal and the bond. And a lot of people think of these together, but I think of them as two separate entities. Seal to me is how well we get union between the teeth to prevent micro leakage, and bond is more about the adhesive strength. Is it going to fall off the tooth? So quite often if you've got a patient and you're worried about micro leakage and new caries, that's an issue with sealing. You don't want marginal leakage, you don't want discomfort, sensitivity. The bond is about making sure the restoration doesn't fall off. Traditionally, glass ionomers, when you bond them, you know, they bond well, but the inherent strength of the glass ionomer is often weaker than the bond strength. So we often get failures cohesively in the glass ionomer. So they don't bond particularly well, glass ionomers, but they have exceptionally good seal. So I think, you know, when we start to move to some of the resin reinforced glass ionomers, you can increase that bond, but you want to make sure you don't lose any of that sealing ability as well. So it's quite a tricky area, and I don't think there's a simple answer. So, you know, I simplify it down to this. When do I use it, when don't I use? And certainly the most common things that I use my glass ionomers for are my high caries risk patients, where I want to reduce disease and get stabilisation, where aesthetics is not a high priority, where there's only moderate functional load, where I've got some compromised tooth substrate that I want to try and strengthen, or I can't get ideal moisture control. Now, I'm not talking about getting it totally wet or totally contaminated, but just minimum. And then if there are economic or environmental restrictions. Only times I definitely don't use it are where I want high strength, where aesthetics is not a high priority, or if I've got a high functional load. And the one we mentioned before, the acidic oral environment. For years people used to say to me they never used glass ionomers in that acidic oral environment. And they were worried about the restoration dissolving, but I want to take it off that list because I don't think it should be there. I want to put it on the when to use, because in my hands the use of glass ionomers is critical for those acid environments, because they're the patients that you need to protect as much as you can. Now, I do a lot of this with my patients. This is what we call surface protection, and I use the low viscosity, high fluoride releasing materials. We used to talk about, you know, fissure sealing and fissure protection, and that can also involve this aspect of what we call surface protection. So those patients that come in with root caries or the sensitive root surface, you can condition it, clean up the surface. You don't have to cut the enamel, and this is the issue where you've got some enamel and dentine where you want to get reasonably good adhesion. And using these high fluoride releasing materials are great because they'll go on in very thin section. You can get some fluoride release, protect that surface, reduce the sensitivity, and also enhance the oral environment slightly with those materials. As our patients are ageing, we're certainly seeing a lot more recession and sort of the long in the tooth concept, which is coming out with a lot of our patients. We're seeing so much more of this, and a lot of my elderly patients, I don't want to start cutting tooth structure away because I'm finding I'm undermining the tooth material. I want to try and preserve that as much as I can. So I'm doing a lot more of this surface protection with the high fluoride releasing glass ionomers in my ageing patients. In your hands, how long do you find those types of restorations last? Because that's been something that's been a great source of frustration for me. Yeah, look, I would have to say that some of these will only last maybe 2 to 3 months, and some of them will last 6 months. I've got some cases where I've seen them up to several years later. I guess that what I would like these to do, depending on the risk of the patient, is to keep the patient stable till I can get them back onto recall. Obviously, different environments, they behave differently. The highly acidic mouths are going to go more rapidly, and some patients are fairly aggressive in the way that they get in with cleaning their teeth, and you will find that they destroy it a bit more readily. But I would very frequently see these last at least 3 to 6 months. Of course, we've got to get rid of some of the other risks with the patients as well. If you've just joined us, keep your smartphone handy. Take your smartphone out, go to the browser, go to ScheinTV, and you can use that part of your browser to interact with us and ask questions as we go. So I'm going to move on beyond that surface protection to talk about this fissure protection. I got a series of slides here that my good colleague Ian No lent me some time ago. He got me into this concept of the unerupted tooth, or the partially erupted tooth I should say, where you want to sort of condition the surface and place these low viscosity, high fluoride releasing materials. And his concept here was that we were going to try and strengthen that surface, and that freshly erupted enamel, which is carbonated apatite, we want to make it a bit stronger and turn it into a stronger fluorapatite. I've been doing this procedure for quite some time now in a lot of my patients, and I find it very effective. And in this particular girl, she's just turned 12, she's had some orthodontic treatment underway, she's already had restorations on the first molar, and we've got some fairly deep fissures in that erupting second molar. By doing this surface protection, I'm doing no tooth preparation, just simply cleaning the surface with the conditioner and placing the glass ionomer on. This particular patient I was fortunate enough to monitor, and that's 5 years after I first placed these.
It's impressive.
And so these are still staying there. I was sort of lucky, and these teeth didn't fully come into function because of the orthodontics. But you don't often see the lot of it there, but you see some residual components there. Certainly I had a lot on to start off with, and some of it dissolves, but they can stay for that length of time. So other situation Hen said was quite useful was to go interproximally. Now I hadn't considered this, but he's using an orthodontic separator here to go between a couple of teeth. And the idea here is you've got some small interproximal lesions, and then he's going to get some space in there to get access to those. And then by placing some of the high fluoride releasing Fuji 7 product there on a little interproximal strip and wiping it through, he's creating a coating on the mesial and distal surfaces of those teeth. By doing that, he's creating this nice little seal on that interproximal, and that can be left there. I'll often do this on the mesial of a 6 as the deciduous second molar, the E erupts or exfoliates, and then I can protect the surface of that tooth when it's sort of in that risk time when the children are young. So, you don't do this for all patients, but I think the issue is GlassIonomers have got a great opportunity for doing some very much MI dentistry and protecting that at-risk surface of the teeth in those early days. Other situation where I probably find that I use these is where I'm trying to do the true disease control, and those patients which have got the gross caries and the very poor oral hygiene. Fortunately, this isn't a huge part of my practice, but I do see a lot of these patients unfortunately still around. And these sort of patients, I'm doing the ART dentistry, the atraumatic restorative treatment, scooping out the caries, getting back to a reasonable bit of tooth structure. I don't use local anaesthetic here, and I'm really trying to just stabilise the oral environment. It's not a permanent restoration, and I frequently use the high fluoride releasing materials. People often say, oh gee, it's not very aesthetic, you've either got that bright white or the very pink colour. To me, that's a bonus, not a disadvantage. I use that as a marker for the patient so that when they see that white or pink, it's an area that they have to focus on cleaning more. It's almost like a marker to give them an idea about where they're going to clean. It also brings them back later if they want something a bit more aesthetic, and by that stage you've hopefully stabilised the mouth and they can get into something a little bit more permanent.
We have a question here. Do you find any difference in the longevity of Fuji 7 Pink versus Fuji 7 White?
Not really. The product's very similar. Obviously, the main difference with those two products is the Fuji 7 Pink. It will absorb blue light from our curing lights, not to cure it, but to actually heat up the product, whereas the white one doesn't. So you can speed up the setting of the pink. Personally, I prefer the pink because I can see where I'm placing it. But there are certain patients, and I did have an interesting situation where I placed these in a 22-year-old lad, and he came back that his mates told him he didn't like pink filling, so I changed that one to white. But generally speaking, I haven't seen any real changes in longevity between those two. So look, I think deciduous teeth, another great choice for doing these interim restorations, and we do have other products on the market other than the Fuji 7, and a few of these high fluoride releasing products which can be very effective. Probably one area that I'd like to mention is that the Fuji 7 still has the greatest fluoride release. With the newer products coming out, some are touted as having increased fluoride release, but Fuji 7 and the Fuji 7 EP product do have that high fluoride release, higher than the Fuji 9 Extra and even some of the other new Equia Fort Fill. The problem is, of course, that they're very soluble, incredibly soluble, so they do disappear over time, and if you've got a high-risk patient, they will disappear, so they're really not long-term permanent. I think I like the fact that in some parts of the world it's called Fuji triage, because it's telling us that we're trying to triage the patient. We're not actually, the numbers are great, but after a while we forget why the numbers are there, and I think it would be nice to think about this product as some way of getting disease control. I certainly have moved myself to the use of the Fuji 7 EP product now, and this is the one that contains the 3% CPP ACP, and the EP is basically enhanced protection. So we're getting some increased calcium release as well as the fluoride there. And there's very little change in the strength of this product. So to me, this is the product I would be moving more and more for my environmental control. I use it a lot in my older patients, and this will give you a bit of an idea about what happens with the GlassIonomers. So as you can see in that top image there on the left, root caries on this older gentleman. I placed some Fuji 7 EP in those, and at placement on the top right, and then at 3 and 6 months, and you can see the material is fairly rapidly dissolving. But the really critical issue here is there's no caries there, and this was a high caries risk patient, and what we've done is control the caries risk. Now, how long do I want those to last? Well, I know that I'm seeing him every 3 months because he's in my high risk category, and I can ensure that I can relook at that. But I can guarantee if I'd placed a composite resin there, he would have had lots of caries around those teeth. The concept of GlassIonomers being the sacrificial anode and protecting the tooth, giving their life to save the life of the tooth, I'm a big believer in. So I think there's benefits there. The other area I use this a lot is where I've got these lesions which may be arrested, but you get that margin which is demineralised. And on that image on the top right, you can see there's some demineralised enamel. I'm not going to get good bonding to that with composite resin. So the ideal thing there is to place a high fluoride releasing material, get some remineralizations into the mouth, and once it's stabilised, cut that back and then place my more aesthetic restoration over the top.
And you'd be happy to bond to enamel at that stage?
Yeah, obviously you've got to reassess that, but the risk is that if I keep cutting interproximally there, I'm going to ring bark this tooth and I keep cutting away all of that demineralised enamel, and I'd rather maintain that and try and remineralise it. How long we need to remineralise it for, I generally go for around about 3 months, although some of the literature says that it only needs to be 4 to 6 weeks. But I like to get the patient being more compliant with their oral hygiene habits, getting into a nice strategy of having a healthier mouth. Then I'm happy to put the composite over the top and bond to the enamel.
A question that's come through, can Fuji 7 EP be used in an open sandwich technique?
Absolutely it can. Any of the glass ionomers can. The big risk I'd have with Fuji 7 EP is the fact that it is very soluble. So you are going to get a fair bit of washout. Now, as we'll talk about a little bit later on, washout to me is not a big problem. It mightn't look very nice for the restoration, but it certainly protects the tooth. So as long as your patient's got reasonable oral hygiene and they're not a high interproximal acidity or not getting a lot of plaque accumulation, then yes, use it there. It's probably going to protect the tooth better than any other glass ionomer, but you're going to need to replace the restoration fairly frequently, as it's going to wash out fairly frequently. It's a great educator for patients, and you tell them, look, it's not my fault this is washing out, it's because you're the one that's not cleaning your teeth properly. And I think that's one thing as dentists we often sort of forget, that we didn't give the patient caries or the plaque, we just haven't given them the skills to control it. So it's a big issue around that. So let's move on to the open sandwich, because to me this is one of the really key areas. And I've mentioned the sort of the open-closed sandwich concept, and really I use glass ionomers a lot, and I'm a big fan of them, and I use them as a dentine replacement nearly all the time. But where we've got that deep margin which is down onto dentine and there's no enamel left, then I certainly leave the glass ionomer down as the open sandwich restoration. One of the things is that over the last 10 years or so there has been quite a bit of literature now out on that, showing that it's quite a valid technique, and a lot of people were concerned that it wasn't, but certainly there's a great deal of literature now that says it's quite acceptable. So I'm going to go back to the images you saw before, plus a few more for this particular patient, and if we have a closer look at this, yes, there's definitely some problems with this, and I'm going to say that, yeah, I wanted this patient to improve their oral hygiene. This patient is, dare I say it, a bit grotty with their oral hygiene. They're not looking after it particularly well. There's lots of subgingival calculus, bone loss, there are all sorts of issues there, and a history of large restorations. And yes, we can see there's lots of washout of the glass ionomer, but if again we look closely, there's very little caries. If we really look at that closely, there's not much caries at all. Even though there's been lots of washout, we've protected the tooth structure. These are some of the largest open sandwich restorations I've seen. Probably a little bit excessive in some ways, and I don't think the quality of the work, the way it's been done, has been ideal, but having said that, it's actually done the patient a good service, because this is a high-risk patient, and what's failed here are the restorations, and there's been no more caries. If this had all been done in composite resins, I would be very concerned that this patient would have a lot more caries lesions. So
an improvement on that technique, would that involve less GIC thickness relative to the composite, or? Yeah,
if you want your glass ionomers to not wash out, make them thinner and lower, but the problem is you've got less protection then, because there's less material. And I'm going to cover that in a little bit when we get to the issue of the red and green zones that Craig brought up a few years ago. Because I think, if you look at this, how do you treat it if you do see washout? You can say I've got to replace the whole restoration. I tend not to. I tend to go in and do little slot preps. And you can see I've just cut away a little bit of the composite, got down to that washout area, and you can see it has just dissolved and there is no caries there. So we can go in and start restoring that just with the nice little slot preparations there, provided you're happy that the margins are all clear. And if you improve the contact areas, this is going to go on much better. But which material do we choose here? Do we choose the Fuji 9 Extra? Do we choose Equi? Do we choose Fuji Bulk, Fuji 8, Fuji 2LC? We've got lots of choices here. And I want to move into that and discuss that a little bit more. This article I really liked because it talked about washout, and it said that, yeah, large glass ionomers in posterior tooth tend to fail and fracture and dissolve. But it's the radiograph on the right that I want to show you. You can see the washout of the glass ionomer on the premolar, but on the molar there's quite a big bit of caries. So obviously this is a high-risk patient, but the placement of the glass ionomer means that there's less tooth structure lost. So, I'm going to ask the audience out there, what's more important to you? Whether your restorations look good or whether the patient gets caries? Because that's the big question at the end of the day. I always think I can replace a restoration, but I can't replace any more lost tooth structure. This was the article I was talking to with Gray and Craig. Back in 2008 in Dental Outlook, there was a lovely discussion here about red and green zones. And if we look closely at these images, you can see that keeping the red zone as the high risk zone of dissolution, if you place composite in that area and you place your glass ionomers lower, there's less chance of washout. But of course, as you reduce that zone, there's also less material available for washout. This was again republished this year, and one of the issues I have here is that if your patient isn't cleaning particularly well and they've got plaque and acid interproximally, that plaque's going to look for something to neutralise the acid. And it's going to either take it out of two structure or GlassIonomer. If there's no GlassIonomer there, it's going to go seeking out a bit of two structure and demineralise that two structure. So I preferentially would like to see more GlassIonomer there. I don't place it all the way to the contact area. I totally agree with that. The material may not be strong enough and it may wear through and you'll end up with an open contact. And I also agree that as the GlassIonomer washes out, you do need to replace it, otherwise you're going to get more food trapping and it's difficult to clean and you can get some periodontal irritation. But I think you've got to, as a practitioner, assess the caries risk of the patient. When you choose to do an open sandwich restoration, you need to be very vigilant on making sure the patient can then look after the area, clean it with interdental brushing or flossing, whatever's going to be necessary to reduce the risk.
I guess maybe we need to educate our patients on it as well and say, look, we're placing this here to protect you, but you're going to need to protect yourself as well, otherwise we'll be replacing this filling pretty soon.
Yeah, absolutely, and I think that's one of the big challenges too. Firstly, patients don't quite understand why it's being done, they just think they're getting a filling. And the second thing is I've often had patients go off to see another dentist and the other dentist will say, oh look, you know, last filling's not very good, it's washing out. Whereas I'd say, well, it's probably not that bad, it's just that we haven't done well in educating the patient. But you know, it's very hard to get that balance right. So I think we've now got some materials which might help us a little tiny bit. I really like this article which has come out, which is talking about not just protecting the tooth that we're restoring, but adjacent teeth. And this article talked about the GlassIonomer promoting remineralization on an adjacent tooth. In fact, even more so than the use of fluoride varnish. And I had a clinical case that I had a chance to look at, and you know, this was a case that came in and there was some interproximal caries on that those upper teeth, the premolars and molar. I definitely had to restore the 5 there, and I was not so sure about the distal of the 4. So I placed a little wedge guard there and I took out the caries in the 5 and then took the wedge guard out and had a quick look at that mesial surface and noticed that it wasn't cavitated. So to me, that's a surface that can be remineralised. So I'm going to now go in and place a GlassIonomer as an open sandwich and hopefully not just protect the tooth I'm restoring, but to get some protection of the adjacent tooth. In this case, I'd use some Fuji 8 because I do want to minimise the risk of washout. And of course, the Fuji 8 is one of those resin modified GlassIonomers, and the addition of the resin is going to reduce the risk of washout, but also a little bit less fluoride release. So there is a bit of a balance here depending on this particular patient. So, only other thing that I would point out about washout is if you let it go too far, these sort of things can happen. Not a common occurrence here, but certainly fracture of a composite because you've got an undermining there. It's a good reason why we have to follow up with patients and regularly monitor them, and certainly a reason why we don't want lots of washout. But if you also have a look at the second premolar, the 5 there, I think you'll see there's a bit of caries on the distal of that. So again, I'd like to point out that GlassIonomers protect the tooth. There's no caries on that lower 6, and so maybe the risk of not using GlassIonomers is worse than the risk of having washout.
Do you ever use GIC sandwiches under deep amalgams?
It's possible, absolutely. I still think amalgam is a great material to seal a margin, and we know from the expansion and the fact that you get a really good seal that it's not going to wash out at all. It's obviously very strong. Of course, the issues are one, getting the patient to accept the use of an amalgam, and secondly, it's why would you be placing GlassIonomer on a margin when we know that amalgam is quite good at sealing those margins? I certainly believe that GlassIonomer is a great thermal insulator. I believe that GlassIonomer is a great material for pulpal protection. But I think if I was using an amalgam over the top, I'd rather have the amalgam go right to the margins. So the closed sandwich amalgam would be my option there rather than the open sandwich. So we've moved into our GlassIonomers now, and I want to do a little progression from the sort of original Fuji 9 GP to the Fuji 9 Fast to the Fuji 9 Extra, and then earlier this year we got introduced to the Equia Fort Fill. I always joke that we had not another Fuji. No, it's not now. It's an Equia product. But what happened here is that it was recognised that Fuji 9 Extra was actually highly soluble. One of the nice things about Fuji 9 Extra is it's got good aesthetics. It's very translucent, and it's got a highly reactive glass, which means it sets really quickly. Problem is with that highly reactive glass, it's also quite acid soluble. So I think the movement to Equia Fort Fill was an opportunity to get something which is a little bit less soluble and also have good fluoride release. The traditional, conventional Fuji 9 series, the glass particles and polyacrylic acid we were aware of. The modification with the new Equia was that they included an ultra-fine, highly reactive fluoroaluminosilicate glass. Now, while I don't want to get too technical about this, what this basically meant was that it became less soluble because the matrix was super enriched with ions. So with the slight amount of solubility, you got more release of fluoride and calcium ions as well. So it's actually a far more effective way of protecting the tooth with being less soluble. So in essence, it's starting to replace the Fuji 9 Extra. In my hands and when I use it clinically, it doesn't appear to have quite the same aesthetics as the Fuji 9 Extra, but certainly a very nice product. And the data would tell us that there's a significant increase in fracture toughness with the Equia Fort Fill, and also an increase in fluoride by 20% over the Fuji 9 Extra. Still not quite as high as the Fuji 7 we mentioned before, but you know, these are good things, and this is why the manufacturers are continuing to work to give us better products. And then just when you thought it was safe to go out, they've introduced some new products on you. And you know, we've now got the Fuji Bulk, as I mentioned before, the Fuji 8. Now Fuji Bulk is probably the newest entrant onto the market and only just hit the Australian market now. Fuji Bulk is a product that's been worked on for some time, and it's got incredibly low solubility, even less solubility than the Equia Fort Fill. It's got the least solubility of all the conventional glass ionomers. It doesn't have quite the same fluoride release, but interestingly enough, the chemistry of this is quite clever in that it's producing a lot of protection to the adjacent tooth structure. So it's becoming one of my materials of choice for my open sandwich.
How is it giving protection without fluoride release?
Yeah, it's a really tricky one, and I did talk directly with the manufacturers on this, and they've kept it as a confidential trade secret, as happens. But they would give me some data, and I'll show you a little bit of the data later, that there is some fluoride release, but the other ions inside the product and the way that it interacts with the adjacent tooth structure tends to make it very protective. So I think we're going to hear more about this product as the manufacturers make it. But in a commercial market, they're often not willing to tell us everything. I've taken some of these extracts out of the Fuji 9 brochure because I was trying to get some information out of this. And if you look at this closely and we look at some of the indications there, they talk about the Fuji Bulk being a really good acid-resistant material, and the Fuji 8GP is being a very good open and closed sandwich material. Now I have to say they're my two materials of choice now for open sandwich. The Fuji Bulk, particularly where I want protection of the adjacent tooth structure and minimal washout, and the Fuji 8 where I want absolutely no washout and happy that there's not quite as much protection of the adjacent tooth structure. I am not using the Fuji 9 Extra anymore. I think it's a bit too soluble to be used in open sandwich. It's still fine if you're using it, but you just got to make sure your patients are very healthy around that and making sure they're looking over it. And there's some data coming out, and again, this is manufacturers' information, that a lactic acid challenge where you've got pure composite resin, which is on the right-hand side, results in some demineralization of the adjacent enamel. But when you put the Fuji Bulk in and expose it to the lactic acid challenge, you don't get any demineralization. So there's more research to be done on this, but I think we've got some great products out there, and it could be more and more. I won't go into detail on this, but one of the things I do want to point out about this is the moisture critical time with the Fuji 8. While it's a lovely resin modified material and we cure it with the light, and well, you don't cure it with the light, it's an all resin material. I should point that out now. The Fuji 8GP, while it's a resin modified material, it's not light curable. It's got a chemical set resin with the chemical set GIC, as opposed to the Fuji 2LC, which has got the light set resin and the chemical set GIC. So slightly different materials there. But being a chemical set material fully in the Fuji 8, it's got a fairly long moisture critical time. You've got to wait 3 minutes before you can get any moisture near it. And in fact, you need to wait 6 minutes before you can start trimming and polishing it. Now that's an eternity in the clinical practice.
Does that moisture include things like Fuji Bond LC if you're using it in a sandwich technique?
No, absolutely not. If you're using a hydrophobic resin-only based bonding system, it's fine. What we have to be careful of though is if you're going to put an all-in-one type bond over the top of this, and some of these are aqueous based solutions, so the all-in-one etching and priming systems or aqueous primers, you don't put those on your glass ionomers because they will actually create some moisture contamination.
Until after that moisture
critical time.
Understood.
So for those that want to move forwards quickly, they need to use purely the bonding component. So if you've got a 2 or 3 bottle system, use the last bottle, because that last bottle is the one that only contains the resin. It won't have any of the aqueous primers in it.
Well, that brings us to a question that came in a little while ago about Fuji 2LC, whether complete light penetration to the bottom of a proximal box is too much of an issue because of that acid-base setting reaction. Do we need to worry about that, or should we essentially just switch to Fuji 8 now?
Yeah, I would switch to Fuji 8, I have to say. But I have to say that also that the Fuji 2 is a really good material. I think with the new generation curing lights, they're very powerful and they can cure to great depth. But of course, when you're using that, you need to build it up in increments. And if you want to have a larger amount, you're going to have to put the Fuji 2 in a few increments, whereas the Fuji 8, we've got a true bulk fill type resin modified GIC.
So we do need to worry about complete light exposure for Fuji 2?
Yeah, I do believe so. Even though, as I said, the curing lights are pretty good, I would probably prefer to go to something which is a chemical set rather than a light set material. Okay, so I tried to put this into a bit of a table, and it's a bit messy this, but the colour coding corresponds to the actual capsule, so you can have a look at this. And as we zoom in on this, you'll probably be able to see that a couple of things there. I've just ranked these from highest to lowest in relation to fluoride release, solubility, aesthetics, compressive strength, fracture toughness and moisture critical time. Not easy to do this exactly, and I gave the manufacturers quite hell when I put this together because some of their test methods are different. But what I really wanted to show with this is that, you know, Fuji 7 is great for fluoride release, but it's very soluble. The Equifort fill, great fluoride release, fairly good compressive strength, but only average aesthetics and solubility. Fuji 8, not as much fluoride release, but really low solubility. So you've got a good product in there and fairly good compressive strength, but the moisture critical time is the issue with it on the other side. So, you know, I think you've got to have a look at that and work out which of the properties which are most important to you as a practitioner and which are those that you're looking for as an outcome. And that'll help you select the material that you're wanting.
When you talk about fluoride release, does that relate to fluoride recharge and re-release, or are they different things?
Absolutely. All glass ionomers are a very complex interaction. They are ion leachable and they can also ion absorb. So they are interactive with the oral environment. Obviously, if you've got a good oral environment where you have times where you've got increased fluoride, then they will uptake the fluoride. If you've got a situation where it's always high acidity or there's always low ion there, then it's going to leach out all the time. So you've got to make sure that your patient goes through that increased material. Look, just finally on the Fuji 8, just to mention that, you know, it really is need to be moisture critical, and if you're doing these as posterior, as full restorations, you need to wait that 6 minutes before you polish them. I tend to use them mainly for my open sandwich restorations. I do occasionally these hero rescues where I've got the really badly broken down tooth, lots of caries in this, and I've just used this to bond the whole thing together. It's amazing how strong that can be in holding, you know, the bridge that would otherwise have been extracted. I use it as a temporary material, and I have my two favourite products, which are Fuji 15 and 16, which no one ever really knows, but that's where I use the combination of Fuji 7 covered by Fuji 8 or Fuji 7 covered by Fuji 9. And it's good for those situations in the really high caries with patients where I want to use it both. So I suppose overall what I'd like to say is that there's lots of products out there. My feeling is that glass ionomers are a great dentine replacement material, and composite resins are a great enamel replacement material. But I think now we should probably have you a quick clinical demo and show what we're going to do with these and how I do my class 2.
Sounds good.
So what I'm going to show you here is I've got a pre-prepared tooth which is on an upper molar. It's an MO cavity on that upper molar. I'm going to have to put my glasses on so I can see what I'm doing with the loupes. Age has done horrible things to my eyes, as with everybody. I need more and more magnification. But what I want to do here is I want to show the situation where we've got this lesion and we're going to isolate it. We're not going to have the time to put rubber dam and everything today, but I'm going to use some of these Garrison bands. And if we can have a look down on the occlusal of this, I'm going to place my matrix band. I very much believe that sectional matrices are the most efficient way of doing our posterior composites. I don't think conventional circumferential bands give us the same sort of separation. I use wedges frequently, not to separate the teeth, but simply to seal that gingival margin. What I'm looking to do is to seal that gingival margin down there and make sure that we've got good marginal seal. Today I'm going to be using the Garrison Compositite system. A couple of different ones is the Compositite and the Compositite XR 3D. I'm going to use this one today. I'm going to have that go over my wedge and we'll sit that down. So this is how I would do my normal restoration for my patients. Once I've got that in place, and again remembering that this wedge is purely there to seal the margin, I'm looking at tooth separation. The separation ring is going to do that. It's going to pull the two teeth, separate the teeth slightly because of the pressure on that mesio in the buccolingual direction, creating the tooth separation. And if we just stick on the occlusal of this, we'll show you that we've actually got our matrix band in place. I'm just going to do a little bit of burnishing in this. And as I was trying to mention there, the placement of the ring and the buccolingual pressure creates our mesiodistal separation to ensure that we're going to get good contact point with the adjacent tooth. I very much believe you still need to burnish adequately against the adjacent tooth. I'm going to show a selective etch technique that I tend to use, and I'm going to use a couple of things. We're going to use some etchant to start off with, just a normal 37% phosphoric acid, and then I'm going to condition the dentine with our 20% polyacrylic acid in the cavity conditioner. The way that I tend to do this is that I like to place the etchant on the enamel first. And when I place this on the enamel, if we have a look at the occlusal surface there, I don't want to take this down. I'm assuming I've got a dentine margin down gingivally, so I'm going to place this as a rim of etchant along my enamel margin here.
Sorry, it's standing by.
So after I've done the selective etch on that enamel, I'm now going to get some of my cavity conditioner, and I'm going to place this on for 10 seconds, and this is actually just going onto the dentine here. So I'm actually doing all of my etching and conditioning, and the etchant is going to go on for 30 seconds and then the conditioner only for 10 seconds, at the end of which time I'm going to rinse the whole lot off together. So I've given a 30-second etch on the enamel and a 10-second condition on the dentine. Make sure we thoroughly rinse and dry that all up, because now we're going to do our open sandwich restoration. And the material that I'm going to choose to do this one is the Fuji bulk. I'm going to show you this material and how well it actually works in here. So I'm going to ask my able assistant here, Peter, to mix my capsule.
Standing by.
Just an issue on the mixing of capsules. I think it's important to realise that with these capsules is that it's not just simply push the button. Certainly you can activate by pushing the button in, but then you should always put them into your applicator gun and give them one solid click. And that one solid click ensures that all the liquid goes into the powder. Thank you, Peter. So we'll get that mixed up there. And what I'm going to do is I'm going to place the material into the bottom of the box form, and then I'm going to use some unfilled resin or some non-aqueous bonding resin as my bond between this material. So we've got our GlassIonomer ready to go now. And now as I place this into the cavity, I'm going to place this right down into the bottom of the box form, and it's going to create my open sandwich.
Do you extrude any GIC before applying it to the tooth, or you go straight in?
I tend to go straight into the tooth. Some people like to extrude the first portion. I look to see that it's coming out reasonably evenly. I think the issue with this is you need, as you see, you need to apply that while it's glossy. I don't like to waste too much time. I will at this stage easily get a ball burnisher, but more frequently I'll pick up a micro brush with some of the bond and I'll use it to help adapt to the tooth. And I'm going to cover all of my dentine with the GlassIonomer. And I want to use this to make sure I'm adapting all the way down. Using that bonding agent, because there's no moisture in it, I don't have to worry about any moisture critical times. And by doing this, I'm making sure there's no air voids or entrapment down inside there. So once I've placed that, you can see I'm adapting that onto the tooth and using that GlassIonomer right down onto the base of the cavity to make sure we've got that in place. I will always now do a little bit of air thinning of my bond. I don't want to get a lot of cooling of the bond, so just a gentle air thin, and you have to make sure that the bond doesn't ripple anymore. There's a general effect when you're blowing the air on the tooth, you'll see that that ripple might disappear. If we can get a close in on the occlusal surface of that tooth again and leave it on there, you'll see that that rippling effect starts to disappear as we thin out the bond. Once that's disappeared, I will then go ahead and light cure that bonding agent over the top of that. Now at this stage, this is a chemical set material, the Fuji bulk. The heat from the light may actually assist in just creating a little bit of setting of the material, but generally it is still a chemical set material. Alright, so we've placed our Fuji bulk material there. Now I'm not going to worry about how long that sets, because now I've covered that, even though that might still be a little bit soft, I'm going to place some flowable resin directly over the top. Now I like using a small amount of flowable, basically to get good wetting in the cavity and to get rid of any voids. A couple of different materials. I do like using this material, Genial Universal Flow, but unfortunately it's a little bit thick as a lining material under a composite. So I use the companion material, which is the Genial Flow X. It's got slightly lower flow. And it really is very good as a very thin layer to go over the GlassIonomer. The advantage of this now is I'm creating good wetting of the surface. I don't have to worry too much about damaging or displacing or distorting my GlassIonomer lining, but I'm creating a good wetting of the cavity. All of the dentine has been covered by GlassIonomer, so I don't need a primer. All I really need to do here is to make sure that I have covered all of my GlassIonomer with that flowable material.
The Genial Flow X also has greater radio opacity than
it does. The Genial Flow by itself has some issues around radio opacity, but the Genial Flow X has much improved radio opacity. So we just make sure that we've got good adaptation. I'll take an instrument down in there and make sure that I've got no voids. And if necessary, we can just adapt it into the cavity to make sure there's no voids down in there. I may do a very light air thin of this to make sure that there's no entrapment. And then once we've done this part of it, we can go in and cure that. And then we'll start to build up the tooth with the increments of composite in any order that people particularly like.
A question from earlier, do you etch fresh GIC for the sandwich technique if we're worried about moisture contamination?
No, as you can see there, I went straight into the bond. I don't like to etch freshly placed GlassIonomer. The only time I will etch glass ionomer is after it's been a restoration in the mouth for some interim period of time. And if I'm cutting it back and using it as a base over a composite, then I'll etch just as I'd etch the enamel. Glass ionomer that's freshly pasted has got plenty of ability to bond mechanically to the composite that's going on top. Of course, if you're using Fuji 8 or Fuji 2LC, there's resin in those products, so there's absolutely no need to etch. The resin and those components will bind each other together. So in this technique now, we've done basically the base and where the glass ionomer goes, and we just build up our increments of composite over the top of that. Given the time frame we've got tonight, I won't go through the whole process of building up our increments on the surface, but I think I would then normally go ahead and I'd use one of the materials like our genial posterior. I'd get a portion of that and I build it up against the matrix band and I create my initial margin out of the composite resin. I can then take off the matrix band and I've in essence created a class 1 cavity by creating my gingival margin first of all. So getting a small amount of the material, building it up into that proximal area. It doesn't need to be a large amount, but quite often what I'll do is I'll just get a small amount of the material and I'll place it into the box form initially, and then I'll shape that and start building that up as if I'm building just up the interproximal margin. And you can start building that up, and as you can see in that sort of situation there. And as you build that up further and further, you make sure you've got adaptation nicely to the tooth. There's no air bubbles entrapped. And once you build up that occlusal margin right up to the marginal ridge, you can then restore the rest of the tooth with some increments and get a nice final restoration. But I think the idea with this is that we get a really nice adaptation of the glass ionomer. There's continuation of treatment after the glass ionomer. You don't have to wait for 3 or 5 minutes before you go ahead, but you can continue immediately on by placing that non-acidic or non-aqueous bonding agent. Some of the products around, for example, we have products like the G-Bond, and there are other products like the Genial Bond. These are products which are all in one system, and they're usually acidic. They usually have some aqueous component to it, and I wouldn't be placing those directly over my glass ionomer. I prefer to use just a straight hydrophobic resin as my bonding agent.
So we've had a question, apparently some people have missed the bonding part. Do you mind doing a quick recap?
Certainly, we'll go through that bonding issue again. So, as I said, what I would normally do is that I do all of my etching and conditioning at the beginning of the preparation. So we're going to place the etchant over the tooth on the enamel. We place the conditioner, in this case cavity conditioner, 20% polyacrylic acid, and we wash all of that away. Once that's washed away and dried but not desiccated, I'll then place the glass ionomer. I don't place the bond at that stage because I want adhesion between the glass ionomer and the tooth structure in the open sandwich. So we place the glass ionomer down and then we place our bond as a way of adapting the glass ionomer on. So I place now a hydrophilic bond only over the top of that glass ionomer. Now obviously we're using a situation here, I want to cover all of the existing dentine with the glass ionomer. If I've got some exposed dentine and you're not going to be covering that with glass ionomer, you can use a dentine primer as well. But in most instances, I want to cover the dentine and then just use a hydrophilic only bonding agent. So again, if you've got a multiple bottle system, 2 or 3 bottles, use the last bottle, the one that doesn't contain the aqueous solution or the acids. And then we just place that, adapt it, air thin it until you don't get the rippling on the surface, and then light cure that for 10 to 20 seconds, depending on manufacturer's instructions. So I think that really what we're seeing here is a simplified way of creating your restoration, of building it up. I think that you've got lots of choices with glass ionomers there. If I was to simplify what we've discussed tonight, I think that as a clinician you've got to work out which products and what outcomes you want. If you want high fluoride release, obviously we use the higher fluoride releasing products. If you want low solubility, you use products that contain resins or have got low solubility. I tend to use 2 products mainly in my practice, which are the Fuji Bulk, which has only recently become available, and the Fuji 8. I find that they're particularly useful in those cases where you've got risk patients, the high caries risk patients. If you've got a patient that's very low risk, it doesn't matter what you use. It's really only where you want to get good protection. And then ultimately you've got to decide what's more important, whether you get a little bit of washout or whether the patient gets caries. And ultimately, I'd like to think we're doing something to save the tooth rather than worrying about the final shape of our restorations, which can be easily replaced.
We've had comments about isolation and rubber dam. In a live patient,
yeah,
what would you normally do?
I would be lying if I said I did every tooth under rubber dam. I try and make sure I get isolation. I will often use retraction paste or retraction cords to help that gingival margin. I'll often find trying to put rubber dam on may actually create more concerns than it solves them. Certainly I like to use rubber dam whenever I can, and it makes the life a lot easier. I think with a good dental assistant, good isolation, and particularly with deep margins, some sort of gingival retraction to make sure you're not getting gingival oozing that you can get away without the use of rubber dam. but it's only in selective cases. If you can't get good isolation, then you probably shouldn't be doing the GlassIonomer, shouldn't be doing the posterior composite in the first place. But having said that, we know that the GlassIonomers are a little bit tolerant to moisture, but not a flooding amount of blood and liquid.
Nice.
So I hope that we've covered a fair bit of ground tonight. I'm not sure how many other questions you've got coming in, Peter, but we're almost at the end of our time.
I'm sorry we haven't got to all of them.
Yeah, there's quite a lot of stuff there. Look, as I was saying before, we've probably got a full day's worth of information on GlassIonomers, and to try and squeeze it into an hour is quite difficult. But I think one of the big highlights is that we know that there's lots of new products coming out. Lots of different manufacturers are producing lots of different products, and I think the insurgence of all the new products is telling us that manufacturers recognise different clinical situations. They're not stagnating, they're not staying still, and we've got lots of opportunities. I'd like to finish by going back and asking that question that we asked at the beginning about which GlassIonomer would you use in a deep interproximal open sandwich restoration, given now the discussion we've had tonight. So the same sort of thing, you can go back onto the phones, I guess, and they can go back and answer those questions. Now you've had a chance to look at that and go through it all. It'd be interesting to see what the practitioners feel about whether it should stay the same or not. You remember before, a lot of people wanted to use the Fuji 2LC and the Fuji 9 Extra. Maybe there's been a change in heart. Maybe people are going to go to none of the above now. But I certainly think that I changed. I used Fuji 9 Extra for many, many years. I used it very effectively because I liked the product, it's fast setting. Then when the Equia Fort Fill came out, I thought this is going to be great. And then when the Fuji Bulk came, it gave me yet another level to work with. So we've got lots of options. So I think we might have a couple of those final results coming in now. And you can see now Fuji 8 and Fuji Bulk are getting a bit more airtime. So I think there's been a fairly big shift in preference of materials there. And I think that that's hopefully going to reflect on what people are thinking a little bit more about their restorations in posterior teeth.
Well, that's all we have time for today. I'd like to thank my guest, Prof. Ian Myers, for joining us on this episode. I'd also like to thank you, our audience, for joining us this evening. I hope you've enjoyed the show, and I'd like to remind you that if you haven't already done so, you can click the button below the video to register for your CPD certificate. To gain the CPD point, New Zealand viewers need to email events@henryschein.co.nz with the subject line Webinar 2015 as verification of viewing. They'll receive their CPD number by return email. Henry Schein would like to thank GC Australia for generously supporting this episode of ScheinTV. For information about GC products, please visit the Henry Schein website. Henry Schein looks forward to seeing you for the next episode of ScheinTV.